Hello and welcome to you all to today's series of short topic discussion from viSE Academy. And we shall be discussing today on the very important topic and most frequently asked in most of the entrance examinations, the management protocols of carcinoma testis. It's a very complex algorithms and a structured guidelines which you need to know so that you can score much better in the examinations and also provide the best management for the patient. If you know the management protocols, it is very simple and you can give the best treatment to the patient. If not, you would go ahead with the management that is given by this guy in the movie Sacred Games. If you had seen this guy in the Sacred Games, you know what treatment he gives for any testicular problems. So don't go like this guy and go for a structured and laid down guidelines. And in today's series, I shall make an attempt to help you understand and simplify the concepts of management of carcinoma testis. So before we go ahead into any intricate matters of carcinoma testis, I will tell you, and I'm repeating again, stage the patient, stratify the patient, risk stratify the patient, and 3, assign the patient to a treatment based on the risk category, and 4th is simply follow up the patient and treat accordingly. So again, it's a seminoma and it falls into clinical stage 1. And then after the step 1, I go for the step 2, that is a risk stratification. That is in the risk stratification of seminoma, you consider 2 things. Just like in NSGCT, you have considered 2 things, that is the LVI and embryonal carcinoma presence. Here you consider 2 things, that is involvement of rete testis and a tumor size of 4 centimeters cutoff. If none of these 2 are present, you consider it as a low risk and you offer the patient a surveillance. Or if the patient is falling into a high risk category, that's if the rete testis is involved, or if the size is more than 4 centimeters, you offer the patient a single dose of carboplatin. That is the management of CS1 seminoma. Very simple. Let's go to the Cs2 seminoma. Again, it's divided into clinical stage 2A and clinical stage 2B. There's not much of difference. Either 2A or 2B, you offer the patient with 2 options are available with you. One is either go for a radiation therapy, or you go for the 3 cycles of BEP. Very simple. But in a clinical stage 2A, that is, you offer 30 grays of para-aortic plus iliac. That is basically the dog leg radiation therapy. That is 30 grays only you offer if he is a stage 2A. However, if the patient belongs to stage 2B, you offer 30 grays DLRT plus 12 grays local booster to the area where the mass is present. So a total of 42 grays is given in clinical stage 2B. However, a dose of 30 grays is good enough in a clinical stage 2A. That's it. Not much of difference in 2A and 2B. So you can offer either radiotherapy or chemotherapy based on the patient profile. Let's go to the clinical stage 2C and 3, that is the advanced seminoma. As you all know, there is no poor risk prognostic category in advanced seminoma. There is only good and intermediate. So after you stage, then you assign the patient to good or intermediate. If the patient falls into good risk category, the green color which you're seeing right now, offer him 3 cycles of BEP. Very simple, very simple. If the patient falls into intermediate risk, offer the patient 4 cycles of BEP, just like same as the management of NSGCT. And now let's see the management of residual mass or the progressive mass after chemotherapy. Here there's a difference in the management of seminoma and non-seminoma. So here's a patient who has been diagnosed to have seminoma, and this patient has underwent some form of treatment in the past, and now after the treatment you follow up the patient, and he has got some residual mass. In the residual mass, It could be either a necrosis or a viable or